Dear friends and colleagues, this is the second part of the vertigo talk. This talk deals with episodic vertigo syndromes. The first question is, one common problem is episodic vertigo lasting for 3 to 4 hours without any other complaints. What conditions cause this type of presentation and how to differentiate these conditions clinically? How do you approach in the case of episodic vertigo? There are many causes of episodic vertigo, the most common ones being manias and vestibular migraine. But there are also other causes like vestibular paroxysmia, TIA, superior semicircular Dixon syndrome, and many non-vestibular dizziness like panic attack, syncope, etc. Now, how to approach a problem of episodic vertigo? The most important question you ask is the duration of each episode of vertigo, which give a clue to arrive at the diagnosis. For example, if the duration is less than 5 seconds, think of two conditions. One is phobic vertigo, the other is vestibular paroxysmia. The duration is between 5 and 90 seconds. The most common one is coming under this category is benign paroxysmal vestibular vertigo. Second is vestibular paroxysmia. If it is 90 seconds to 20 minutes, TIA, migraine, and lastly vestibular paroxysmia come in this category. If the duration is between 20 minutes to 24 hours, think of Meniere's disease, less commonly TIA and pre-hepatic vestibular. The duration is more than 24 hours, think of vestibular neuronitis and CNS disease. Now the question here is episodic vertigo lasting for 3 to 4 hours. The two important conditions under this category are the vestibular migraine and Meniere's disease. Now what is vestibular migraine? This is the most common cause of recurrent spontaneous vertigo attacks. While vestibular migraine can develop at any age, it generally affects persons with a long-standing history of migraine. The migraine attacks can be replaced by isolated vertigo attacks lately in the post-menopause women. The so-called benign paroxysmal vertigo in childhood is a pediatric migraine variant of vestibular migraine. Now, in vestibular migraine, the vertigo can present as a spontaneous vertigo, or positional vertigo, or motion intolerance. The attack duration can vary from minutes to days, usually less than minimum of 5 minutes. It can alternate with migraine attacks many times. The headache may begin before, during, or after the dizziness, and sometimes or often absent during that time. Associated accompaniments of migraine like nausea, vomiting, photophobia, phonophobia, osmophobia cannot occur in vestibular migraine, but these features are often absent. Many times they present only with isolated. Hearing loss or tinnitus sometimes occurs, causing confusion in Meniere's disease. Examination can reveal any type of nystagmus, maybe central or peripheral. The other condition of episodic vertigo lasting for 3 to 4 hours is Meniere's disease. This is relatively uncommon cause of dizziness. As you know, here the patients classically present with episodic vertigo, accompanied by unilateral tinnitus and oral fullness, often with reversible sensorineural hearing loss. The episode lasts 4 minutes to hours. So the next question is, how to differentiate vestibular migraine from Meniere's disease because some overlapping features are there. What are the dilemmas? At an early stage of the disease, it may be difficult to differentiate Meniere's disease from vestibular migraine if the oral symptoms are absent in Meniere's disease. Even with the presence of oral symptoms, it may be difficult since auditory symptoms like hearing disturbances, tinnitus, and oral pressure have also been found in 38% vestibular migraine patients. Moreover, the prevalence of migraine in Meniere's disease is reported to be twice as high as in healthy subjects. Now, under this problem of their conditions, how to differentiate? A history of repeated recurrence over years without permanent sequelae favors vestibular migraine. Continuous tinnitus and persistent deafness are features more favoring Meniere's disease. The most reliable distinguishing feature is the low frequency hearing loss in Meniere's disease. It persists even between the attacks of vertigo. Now, coming to the next question. In BPPV, we usually do not do any investigations and teach them exercise and send them off. Is it always benign? Is there any situation where this can occur in 7 days? Even though positional vertigo is more often benign, not uncommonly it can occur in central lesions due to lesion near the orthoventricle, often the spina nuclei or the cerebellar vertex. The causes can be MS, cerebellar tumor, or nodule malformation. More often, it is apogeotropic type of horizontal positional vertigo, which mimics a central lesion. Now, is there any way by which we can differentiate a peripheral from central positional vertigo? Yes, the type of nystagmus, the onset, latency, and duration can differentiate between the two. In peripheral positional BPPV, the most common one is that posterior distance BPPV, where the nystagmus is vertical and torsional. If it is horizontal canal, the nystagmus is horizontal beating. Pure vertical nystagmus, like upbeat or downbeat, or pure rotary nystagmus, if it occurs during position change, there is a central type. As you all know, there is usually latent period between assuming the offending position and onset of vertigo in the case of PPPV, but there is no latent period in the case of central positional vertigo. Even if you keep the head in the offending position, the duration, the vertigo subsides in peripheral lesions, whereas the vertigo will continue to occur in central lesions. If you bring the head in the offending position again and again, it gets fatigued out in peripheral causes like classical PPPV, whereas it will not fatigue, it will continue to recur every time you assume that position in the case of central positional vertigo. So these features by which you can differentiate between the two. Coming to the question 5, it's a story of a middle-aged person who combines dizziness and imbalance when he gets up and stands. There's no problem when he continues to walk. And he tends to hold on to something while standing or sits for the fear of fall. What is his problem? Is it BPPV? And how to that problem? This type of dizziness, that is dizziness occurring only when standing up, not while walking, it is called postural dizziness. There are various conditions which can produce these complaints from patients. Most common would be hemodynamic orthostatic dizziness like postural hypotension, visual syncope. Second is postural orthostatic tachycardia syndrome, which can also present with postural dizziness. Orthostatic tremor patients, they may come with imbalance during standing, may come with combined postural dizziness, and BPP. Other three conditions like bilateral spulopathy, postural imbalance due to atypical Parkinsonism like PSP, sensory neuropathy can also present with imbalance while standing. But these latter three conditions, they will have imbalance even while walking, so it will not qualify truly for a postural dizziness syndrome. The postural hypotension I will not say. Only point removed is that even operator vertigo and nystagmus can occur in approximately 30% of the patients in profound hypertension. The other condition is postural orthostatic tachycardia syndrome. It is characterized by sustained heart rate increase of at least 30 beats per minute or a heart rate of 120 beats per minute or more in 10 minutes of standing in the absence of orthostatic hypertension. It is usually seen at the age of 15 to 50 years or in females. They also present with postural dizziness. This condition one should not miss, that is orthostatic tremor. The patient, they may not combine of tremor to compete with tremor, they compete with being imbalance while standing. They tend to sit or walk about to avoid the dizziness. Even though they have a postural tremor of the legs, it may not be a prominent complaint. The clue to diagnose this condition is that dizziness disappears on walking, and you can look for the fine tremor of the legs by standing. BPB is not a problem in diagnosis because it is therefore a true vertigo spinning dizziness and is precipitated by change of position in the bed and the cells and bending down, unlike a postural dizziness. But when they occur only on getting up, it can come to the different diagnosis. Now, the other question is episodic transient vertigo lasting for 2 to 3 minutes. Short duration vertigo. Now, some people complain that they get dizziness lasting for a fraction of a second, less than a second. They do not fall, but tend to catch hold of something or slow down their walking or because of the fear of fall they see. This complaint is not actually vertigo. It's usually seen as a part of organ process vertigo, known as vertigo, about which I will talk about later. The second scenario is that episodic short duration vertigo lasting for 30 seconds to minutes is vestibular paroxysmia and sometimes in ischemic attack. Coming to vestibular paroxysmia, the leading symptoms of vestibular paroxysmia are recurrent, spontaneous, short attacks of spinning or non-spinning vertigo that generally last seconds to minutes and can occur up to 30 or more times per day. It is akin to a trigeminalgia due to neurovascular convolution of the retina. The cardinal feature is that these attacks are precipitated by particular head positions or hyperventilation and may be influenced by changing the head position. Unilateral hypoacusis or tinnitus can occur during the attack. They are precipitated, they are improved markedly with carbamazepine, even with low dosage. There is no brain symptoms or signs during this period. As you can see, this picture is due to neurovascular compression, compressing the hyperactive, compressing the eighth. There are many differential diagnoses. The important ones which can cause confusion in the paroxysmia. The clue is that the characteristic brevity of these particular episodes, seconds to minutes. How to differentiate the superoblique myoclonus? Superoblique myoclonus produces vertical rotatory oscillopsia. The clue is that this disappears during closure of the eye, as the vertigo do not subside. How to differentiate from BPPV? In BPPV has got the classical typically crescendo, decrescendo, vertigo, and nystagmus, precipitated by change of position. Vestibular paroxysmia is not regularly triggered by positioning maneuver, unlike BPPV, and moreover, vestibular paroxysmia is also precipitated by other head movements like forearm movement in case of vestibular paroxysmia. Another condition is superior subsacral dehiscence, about which we begin talking to later on. Here, the classical symptom is that the vertigo is elicited or precipitated by intracranial pressure changes as during vestibular maneuver or acoustic stimulation of the sound-induced vertigo. Panic attack can sometimes cause confusion with Differential Dizziness, but here panic attacks usually last longer than the typical vestibular paroxysmia. Moreover, the anxiety appears first before the dizziness. The real problem comes or differentiate from vestibular migraine and Meniere's, but migraine Meniere's here the duration is very short, it's already told. And vestibular migraine and Meniere's seldom repeats on the same day, whereas vestibular paroxysmia occurs many times a day. The family history, absence of family history and treatment response, good treatment response to carbamazepine, other points favoring vestibular paroxysmia. The question number 7 is, this is one patient who gave, his complaints were like this: I get dizzy whenever I hear loud noise like honking of a vehicle. I had fallen 2 times when the sound was very loud. Sometimes I can hear my chewing, belching, borborygmi, and even my footsteps in the backyard. What do you think about these diseases? These symptoms are typical of superior semicranial dehiscence or other causes of perilymphatic fistula. Superior semicranial dehiscence refers to a focal loss of bony wall of superior semicranial. There are 3 cardinal symptoms. One is the pressure and sound-induced vertigo. That even between a self-manner or straining, they get vertigo called Henneberg sign. When they hear a loud sound, they can get a vertigo called the Tulia phenomenon. Another interesting fact is the bone conduction hyperacusis, meaning that this manifests as symptoms of autophony, that is, hearing one's own voices and as loud or distorted. Percentage tinnitus, audible eye movements, audible footsteps, chewing, bowel movements, etc. They have combined of chronic dyssynchrony as well. The examination shows eye movements in the plane of superior semicircular canal, where the ear canal pressure or loud tones are applied to the ear. One simple bedside test which you can do is a tuning-fork test. When a vibrating tuning fork is placed on the sternum or the leading malleolus, the patient can hear the sound in the affected ear, suggesting the cacophony. The ideal test is high-resolution CT scan, which can show the defect, or audiometry can show the increased bone conduction and decreased air conduction, mimicking a middle ear deafness. And this loss of this sensitive airborne gap, and this phenomenon occurs most significantly at the low sound frequencies. This you can see the defect of the CT second panel here. In high resolution CT, you can make out the defect. The audiometry shows that the conductive deafness, the air conduction is much better than the air conduction. Air conduction loss is mainly for the low frequency tones. A patient complains of continuous vertigo and dizziness. He always carries a cane for fear of fall. What do you think about this condition? If somebody complains that he is having continuous vertigo, it means that he is not having any vertigo. Most likely, it is what is called as a PPD, that is persistent postural perceptive dizziness. Newly suspect it when the patient sits in front of you by holding on to chair with the fear of fall. Think of this condition. These patients walk with cane most of the time when they go out of the house and walks very cautiously, and on examination, you don't get anything on the examination. The usual history of these patients are like this. They will complain, I feel as if my body is weak, like I'm on a boat. I feel I am about to fall. I feel as if I may pass out. I feel spaced out, as if my legs are spongy, as if I'm floating. Now, this condition, the persistent postural perceptual dizziness, is the second most common cause of dizziness, accounting for about 15 to 20%. This term has replaced the previous terminologies like phobic postural vertigo and chronic subjective dizziness. This is a chronic functional disorder of the nervous system characterized by non-spinning vertigo and perceived unsteadiness, lasting for prolonged periods of time after the vaccine being severe. The symptoms can be exacerbated by three factors. One is upright posture when they stand and walk about, active and passive motion, and exposure to moving visual stimuli or complex visual patterns or crowded places. For example, they find it extremely difficult to walk on a carpet like this, zigzag lines or flowered carpet like this. And they also find it difficult to walk in a crowded place, crowded market, because they feel imbalanced during this time. This can be precipitated by an vestibular migraine or a panic attack, or yes, first attack of vestibular neuronitis, followed by this particular continuous vertigo like this. Another question was, recently I had a patient who had been complaining of imbalance while walking for 3 months. No true vertigo, no sensory complaint. The gait imbalance is slightly worsened when he closes his eyes while taking his bath. Examination says everything is normal except that his random walking is mildly delayed. His MRI nerve conduct studies were normal. What do you think about this condition? Could it be PD like already told before? PD should not be used as a waste basket diagnosis for patients who present with non-specific diseases where we cannot find any objective basis for a true imbalance. Some of these patients do have another problem, such as bilateral vestibulopathy. Unless you carefully look for it, you will lose this condition. For a slowly developing neurodegenerative disorder like cerebellar degeneration or atypical Parkinsonism, or evolving episodic disorder like vestibular migraine, can initially mimic triple PD disorder. So usually triple PD is diagnosed as exclusion. Be cautioned if it is a short duration. In practice, there are 3 situations where I have initially thought of the patient having the triple PD, but later on proved to be something else. One condition was bilateral vestibulopathy, second is NPH, and PD, PSP. Certain practical hints for not missing a sinister condition. Always follow up such patients with symptoms of short duration. If somebody comes to you with 2 to 3 years of imbalance with no findings, and it could be the most technical difficult period. Never forget to do a full test if everything is normal, examination is normal. There is also a history of falls, be very cautious. Now, the most important DD in such situations is bilateral vestibulopathy, which usually occur after injections of glycosides, as you know. The patient does not complain of vertigo, and the examination does not show any nystagmus and imbalance. As you know why this is because, as you know, the vertigo and nystagmus is still some asymmetric discharge from the labyrinth. In both labyrinth are affected simultaneously. There is no asymmetry, so there is no vertigo and nystagmus. So only when there is asymmetrical like this you can get vertigo and nystagmus. These people come to you only with gait incidents which may or may not be English by closure. That is how to diagnose. The one test which you, when you question, you always ask for is the presence of history of oscillopsia while walking and traveling. This is not medically useful of the test. I cannot visualize when the head is moving. And never forget to the head impulse test, which is absent bilaterally in such patients. And if the injection being the commonest cause, ask for history of injections in the onset of this imbalance. The second scenario which can be confused is NPH because many a time there may be mild imbalance which before they develop the classical triad. Sinus examination may be normal except short-stepped wide-based gait which may be misinterpreted as a conscious gait of frequency. How to diagnose NPH? Ask for history of incontinence. The patient may not voluntarily because you have told him that it is due to the prostate. And always now forget to the full test in early imbalance. This is one of the tests which again become positive in early NPH. And thirdly, the other condition which can mimic is ESP. The MRI may be normal at this time. Again, look for the full test as well as looking for any early vertical sacroiliac case. So with that, I will stop here. Thank you for your patient listening.